Welcome to Only Oncologists in the Building. I'm Shalan Beg, a health tech realist, here with my colleagues to moderate our next episode.
I'm Shruti Patel, clinical trialist and GI medical oncologist in the Bay Area. Looking forward to our conversation.
Emil, physician scientist and evidence-based oncologist. Let's do it.
So today we're going to tackle the topic of acetaminophen use or Tylenol use and pregnancy. This has been in the news for many weeks. We've seen many different takes, different conversations. There's been some very interesting debate between the three of us on this topic. So, Shruti, you suggested we have an episode on this topic. You've come in with your evidence. Take it away.
All right. So, Tylenol. It's the go to medicine for pain and fever in pregnancy. Some studies suggested that it might increase the risk of autism, ADHD, or intellectual disability in children, which is, of course, an understandable concern. And so I wanted to bring up this study that was published in 2024 in JAMA. So 2.5 million children in Sweden between 1995 and 2019. And prenatal, Tylenol, acetaminophen use was documented in medical and prescription records. And the outcomes that they looked at were autism and then ADHD and then intellectual disability. I think a key part of this paper was that they didn't just compare those that were exposed versus unexposed, which they did do that as well, but they also did a sibling controlled analysis. So they looked at families that had at least two children where one pregnancy included Tylenol or acetaminophen use and the other one didn't. And the design automatically adjusts for many shared genetic and environmental factors when you do the sibling controlled analysis. And these are things that are really nearly impossible to measure directly, like inherited risk for autism or ADHD. And so I think that this actually answers the question that if a mother takes acetaminophen in one pregnancy, but not another, do those siblings have different risks? Because that's really the question that we're trying to answer. And so what they found was when you looked at everybody, Tylenol use showed a very small increase in risk, which they've seen in prior studies. But when you look at the sibling controlled analysis, those small signals disappeared. They went from a hazard ratio of 1.05 to 1.07 down to in autism, the hazard ratio was 0.98. In ADHD, the hazard ratio was also 0.98. And in intellectual disability, the hazard ratio was 1.01. And so I think this really matters because, again, we've seen this in the news. And I have a lot of thoughts, which we will talk about in this thing, about, the way that we message fear in pregnancy. And when we look at the sibling comparison, it strongly suggests that the small associations that we see in these other studies were likely due to familial confounding because they did not control for these sibling analysis. And we know that genetics increase the risk of ADHD and autism in a way that we don't quite understand. Of course, there's certain that we do understand, but there's a lot of genetic kind of parts of autism that we don't understand, which is kind of scary. So to me, the take-home message is that this was a large-scale, carefully designed study, found no evidence that acetaminophen during pregnancy causes autism, ADHD, or intellectual disability. And I think it reinforces the idea that acetaminophen remains safe when medically indicated in pregnancy. And I also think that we need to think about what are the other alternatives in pregnancy, right? So we're thinking about ibuprofen. Is that safe?
We're not talking about that just yet, Dr. Patel. Right now, we're talking about epidemiological data related to the use of acetaminophen.
I'm getting ahead of myself. I'm excited.
I'm gonna keep you on track.
Let's talk about this.
All right, we're talking about what is the evidence that can show the association between acetaminophen, prenatal acetaminophen use, and the subsequent development of ADD or autism in the child, in the baby that's born. So you're very rightfully highlighting one of the largest cohort studies and a subgroup analysis of siblings that are born within that cohort where one sibling had prenatal exposure to acetaminophen and the other didn't, and that did not show a difference. And that's a pretty robust evaluation because you assume that siblings who were born in the same household by definition would have other confounding variables would be pretty consistent. Generally, we consider a prospective randomized controlled trial as the gold standard to define whether one intervention leads to an outcome or not. And for obvious reasons, that's hard for us to do in this environment. So the data that you have is giving us really strong evidence, and we'll go into some aspects of that in further discussion. Emil, thoughts on this study so far?
So I think this harkens just maybe taking a big step back about a lot of epidemiological concepts that we've spoken a lot, right, on our different episodes. We think of association, think of correlation and causation, so cause and effect. In other words, the notion that if some intervention or in this case a medication is taken, that is the cause of an outcome or event. In this case, autism. It's interesting. This is really, I think, when these large scale studies are done. Obviously not prospective, so looking back, there are always inherent risks in that. But kudos to the investigators for trying something at such large scale. I think a couple of things that come to mind in the design or of even retrospective analysis is that these are siblings, but inherent when you have siblings. No one's identical to a sibling unless it's an identical twin, right? And even then, sometimes there are some social and other traits that differ, and some of that may have impact on any diagnosis of autism, somewhere on the spectrum, ADHD. I think that's just something to keep in mind. So while there are similarities, same household, so social factors, environment, nature and nurture, and all that, there are things that are just different enough, inherent in having a sibling that's not genetically identical, that we have to consider. And I think it's interesting. I didn't know the background for why they kind of picked on acetaminophen, Tylenol in particular. Why that was there some preclinical evidence? What was the intent of honing on that and not doing ibuprofen or other things? And I would say, lastly, I think when we think of not being a board certified OBGYN, but knowing a few very well. So we think of different trimesters. So we think, I think this is from the world of oncology we draw from, right? So some chemotherapies cross that barrier and are safe to give in some trimesters, but not safe to give, usually, like, as we say, in the first trimester. So what might be the effect of this drug, acetaminophen, also called Tylenol, in the first trimester that might differ second or third? So those are a lot of things that go through my mind. I mean, I think it's interesting, but I think the punchline that always kind of just jumps from the research page and into the social media and others news stratosphere, this one really captured the attention of a lot of people in a very interesting way.
Yeah, I think this is a very strong study which failed to show an association between prenatal acetaminophen use and the development of ADD and autism. There are some aspects of this study which limit its applicability in the real world. I think this is, first of all, it's a Nordic study. It's a patient population which is generally considered more homogeneous than other parts of the world, or even the population of the United States. The incidence, if I remember correctly, on this study for autism and in ADD was fairly low. I think it was less than 5%, maybe 1 to 2%, while our reported incidence in the United States for these conditions is closer to 10 or 11%, which tells me that there are other factors which could be influencing the development of ADD and autism in the study population versus otherwise. And then lastly, we've talked about this in our alcohol and cancer discussions, and in our vitamin discussions as well, is to be able to quantify the use of an exposure, which in this case is acetaminophen, the timing of the exposure, whether it's in what trimester it was done, the dose dependency of Tylenol use is not really yes or no. It's like, you're taking 5 times a day, or are you taking it once every 3 months? And those are factors which are very difficult to measure and ascertain in a retrospective study. So while the negative association that this study found is important, I view it as only one flag in the ground to give us the data around this association. I'll have some other studies that I'll bring in right now, but Shruti, what do you think?
Yeah, I absolutely agree that if we weren't being told, like if the messaging wasn't Tylenol causes autism, we would not be talking about, frankly, we would not be talking about this study, because the study does not definitively conclude confidently that in the United States, like you guys are making absolutely great points, right? Um, if we were not trying to find, this is just kind of the first step in like a very long step, as all research is, right? You do the retrospective, then you try to understand the biological, you do a lot of research to get to a conclusion. But when the conclusion is preemptively put out there, then you have to start looking at these studies in a more kind of like every study, you guys all know this, we can critically look at any study, right? That's the reality. Um, and a Nordic study is not going to fully apply to the United States population. There was actually another Japanese study that was just published on September 2nd of this year that also did a sibling controlled analysis and also had similar results. But you could also argue your exact same thing, that that's a more homogeneous population than what we have in the United States and all of that. But anyways, we'll talk about kind of some of the rest of my points that I want to bring up later. But I think that I completely agree with you guys that this is not the end all be all, but because we have put the cart before the horse, I think that's the saying. I think that's the saying. Now we have to look at these studies and see, okay, well, what based on what we have right now, which is not everything, what do we see so
Yeah, I just want to bring up a lighthearted point before maybe being a little provocative. I'm in the land of the ice and snow, as Led Zeppelin once sang in an immigrant song. Here in Minnesota, we're sort of a Nordic population. But seriously, I think there are a lot of fascinating epidemiologic studies, large-scale studies that come out of the Nordic countries in our field of oncology and across the spectrum, I think cardiovascular world as well. So I give props, but I think at the same time, as we balance out how we interpret not just the results at face value, but how they, even if they're true, correlation, causation, or what have you in any study, how do they apply to a more heterogeneous population, for example, in North America? Maybe I'll be a little provocative here, and we'll say it's a bit of the elephant in the room. How do you interpret such a study in 2025, where a lot of, whether it's vaccines over the last decade, or particularly in 2025, there has been, at the highest levels of government, I'll leave it at that from a political standpoint, question about this central medical condition, if you call it that, of autism, about being intent, about identifying, after decades of many studies, intent on trying to find a exact cause, right? Whether it be drug or natural, genetically inherited, or any of the above. This mission that by fall 2025 that stated that the cause will be identified, and maybe not so rigorous science, to be honest with you. So that's why I feel like maybe my question for you, to be enough provocative, is how would the study be interpreted if it came out 10 years ago in 2015? Not 2024, and being discussed so rapidly among the zeitgeist of 2025. Would we be having this conversation, or would autism or acetaminophen, such a common drug that our liver metabolizes, and I think we coach patients, cancer-related pain or other type of common headache or non-cancer issues, 2,000 milligrams per day, or approximately 2 grams a day, relatively tolerated real drug, been around for many, many decades. Be interested in hearing your thoughts about, is this something that's being interpreted in that lens of 2025 and the zeitgeist being different than it was in years and decades past?
I have a even more provocative answer to that. And I feel that because of the way that this conversation started in the last couple of months, people may be approaching this question with preconceived notion and interpreting the data based on what their perspective was before reviewing the data. And part of why we're here bringing in these different perspectives is to air out those differences and really look at the data away from any preconceived notions, and us being honest and demonstrating to our viewers and our listeners that none of us believe that the data is solid in one way or the other. Because when we look at the data which is being cited the most is a meta-analysis of 46 studies which looked to evaluate the association of acetaminophen use with neurodevelopmental disorders. And out of these trials, 27 studies reported a positive association, meaning that acetaminophen use was associated with neurodevelopmental disorders. 9 showed no significant link, and 4 showed a negative association, meaning that there could be a protective effect. Now, for this study, the author said, well, we need higher quality studies than what are out there. We summarize the studies that are out there. The preponderance of those studies suggests there is an association, but there's some that are saying protective. So what's going on here? And we all know in the oncology space, we try to combine all the data, the preponderance of data. In the preclinical space, Emil, you suggested we look at the preclinical rationale. We see in a phase 1 or 2 study, is there activity, and is that confirmed in a phase 3 study? And what do epidemiological results suggest? And very, very rarely we find consistent preclinical data, consistent clinical data, and epidemiological data to support that finding. We're very used to living in a world where some of these data could conflict, and we make the decision on how we're going to move forward based on the risk, based on the benefit, the risk of action, as well as the risk of inaction if we were to implement a specific finding. And to the point that Shruti is probably going to make, and she was starting to make before before I interrupted her, is what other options do we have in that scenario? And what is the severity or the risk of not doing anything in that space? So let's change gears and now talk about and we're going to summarize all this in the rapid fire session. But let's move the discussion away from what is the epidemiological data to demonstrate the association between these to more practical aspects on what that means for the care of people around us, our loved ones, our patients, and people who are listening to us as well. Shruti, you want to take a first stab at that on how you are interpreting these results and how that's changed your perspective in general?
Yeah, I think that I might have like a different view than some people where I generally think that I've had a few friends be pregnant recently. And I think that the way that we treat women in pregnancy is extremely we kind of just, I think, treat them like a vessel for the child, and not really. And to me, this kind of rabid kind of onslaught of like, we see this data, and to your point, we want to thoughtfully, if there is a risk, we want to investigate it. We want to investigate it thoughtfully, instead of just putting the cart before the horse and getting on this and scaring women, because women who are pregnant
Right.
and new mothers are very much at risk of hearing all this and being like, I'm not going to take Tylenol, no matter how scientific you are, no matter how much you know about data, and I'm talking about people, doctors, nurses, like just people that I'm talking to on a day to day basis. And when we think about the alternatives, right, NSAIDs, we know that that's not recommended. We're not trying to give moms opiates for pain. What are our options also to reduce fever when we know that fever can cause neural tube defects? It can cause other, you know, problems to the fetus. We're not even talking about the moms suffering, whether it's in pain and fever. And so I find, to your point about everything in life is a risk and a benefit. When we get into a car and drive somewhere, we are risking getting into a car accident to benefit, right? Getting to point B from point A, right? Every part of life is a risk and benefit. And to overstate the risks when we just don't like fully know them, but based on the data that I have seen and what I know about genetics and autism, I feel very confident telling my friends who are pregnant, my patients actually who are pregnant and undergoing chemo and have cancer, that they can safely use Tylenol in pregnancy. And like recognize that other doctors might have a different, calculus, but that is generally my calculus at this point. And because when I think about the alternatives, I just don't see, if someone wants to invent a new Tylenol that that is 100% safe, which I just that we know, because we don't know that this isn't 100% safe. It possibly is, and I think probably is. Um, I think that that would be wonderful, but that's not where we are right now. And so to discard women suffering, or even risk to fetus with fever, I find very unsettling.
A lot of important points there, right? What is the alternative? So if we're saying, NSAIDs, for the audience, non-steroidal anti-inflammatory drugs like ibuprofen, as an example, naproxen, are, they're generally, some are, if not all of them are clear through the kidney, and Tylenol or acetaminophen clear through the liver. I just come back to this idea of all things in moderation, right? So I would think someone having a fever or pain, they have to have something, and rather than suffer in silence, there's no need for that. Taking some medication, but as I was saying earlier, there's a threshold at which we generally think or believe medically that there's a certain amount you can take in a 24-hour period or cumulatively over a week that the body's normal liver is capable of processing safely. Whether that's altered a little bit during pregnancy, a lot of things are altered in terms of metabolism and other things, drugs or otherwise, in pregnancy, like any other condition. But I was worried that people will read a study like and say, well, that's one less thing I can do, suffering and pain, or even physicians or care providers doing such a thing. And that's why, since I'm drinking from my Avengers mug, Avengers Assemble, and I think of the importance of collaboration and people in that sphere day to day, like I'm not a maternal fetal medicine specialist, but I would certainly depend on their perspective, and people on the front lines helping patients, helping women who are pregnant, and helping to navigate these data and other studies, and just trying to have it safe as possible. But at the end of the day, as Shruti, as you said, everything in life has a risk, and so if we approach this in moderation, and even take studies like this at face value, and if no known association or correlation, then we would proceed with moderation in the dosing of this anyway. Just be careful how we interpret results and not to over or misinterpret them, really, especially.
On that note, let's start our rapid fire acetaminophen in pregnancy edition. Are we ready? So I'd like us all to give our results at the same time. Should we do thumbs up, thumbs down after I ask the question? Does that work? Can you see
Are
if
we going to do like
your
3,
response
2, 1,
mechanisms are working?
3, 2, 1?
No, I'm going to say the
Okay.
question and then we're going to go boom.
Okay. All right. All right.
All right. And hopefully I frame the questions in a way it's actually a yes or no question. We'll figure that out. All right.
Make it clear that you're done with it, so that way we'll be like primed, ready.
All right.
No peeking.
All right. Rapid fire question number 1. Is there evidence suggesting a causal link between prenatal acetaminophen use and autism?
No.
Can untreated maternal fever during pregnancy pose risks to both the mother and the baby?
Potentially, yeah.
Alternate medications to acetaminophen, such as NSAIDs or ibuprofen, can carry a higher risk than acetaminophen use.
I think so.
As of today, there is no robust evidence to substantiate a causal association between Tylenol use in pregnancy and an increased risk of autism. All right. Now what I'm going to do is I'm going to share the FDA's letter to physicians on what the FDA has actually said about the situation. So we stay away from what the headlines are, and let's see what FDA Commissioner Dr. Martin Makary is saying on this topic. So number 1, they're saying an association between acetaminophen use and autism has been described in studies, but a causal relationship has not been established, which is pretty much what we said. And there are contrary studies in the scientific literature, which we also talked about. The association is an ongoing area of scientific debate, and clinicians should be aware of the issue in their clinical decision-making, especially given that most short-term fevers in pregnant women and young children do not require medications. Do you agree with that statement?
I disagree with that statement.
Okay. All right, go for it.
So I think that trying to figure out how to say this. I disagree with that statement. I think that if you're saying that there is no risk to short-term fever, you're just basically, again, seeing a woman as a vessel for carrying the child and not the woman as a person herself. I don't know. I'm sure you guys have had fevers before. They are not comfortable. And honestly, none of the 3 of us have been pregnant before. But let me tell you, that's an added discomfort to the body. And so I just find it a little bit presumptive to say that short-term fevers in pregnant women and young children do not require medications. You're not seeing in the same way that I wouldn't make an assessment that every single pregnant person with a fever every single time needs acetaminophen either. I just can't. You can't make that, I think, generalization. That's my take.
Yeah, I wonder if that sentence, if they would have said that some short-term fevers in pregnant women do not require medications, that maybe some people would be more agreeable. Emil, anything to add on that?
Yeah, if you could, show again the sentence that you highlighted, and then let's read out loud the 1 to 2 sentences that came after it. In the spirit of, I'll just go ahead. So
we're not there yet. We're not there yet.
Oh, okay, I'll go. If we're going there, we're going there. So
Yep.
if you're asking for the entire sentence, that last half of that sentence that you have highlighted, wow, that's a doozy, because then we'll get to the ones that follow after that. That's like this, and it seems to me this letter is saying a lot without saying anything at all, and it's disappointing, quite frankly, to be able to say this, because if people are pointing to this, maybe the average person may not be reading this, but physicians who are helping those patients, if they restrict use of acetaminophen based on this, that's a big disappointment.
I'm not reading it that way. I am interpreting it as saying that some fevers probably don't need to be treated, and be judicious on when you decide to take your medication. The same way, if the 3 of us were to have a fever, we would think about whether we want to take a Tylenol or not. And they're simply just saying, think twice before you take it. But to both of your points, I think it is fair to think that if this is a letter coming from the FDA, that people will give it more credence than otherwise.
I think that if my take on that is, if this was coming in isolation, I might be able to give that grace, right? Of maybe the wording is a little bit, but I don't think that this letter is in isolation, and that's my concern. But
I
And
agree.
we are trying to look at it in isolation by itself, which takes us to the third paragraph. In the spirit of
Mhm.
patient safety and prudent medicine, clinicians should consider minimizing the use of acetaminophen during pregnancy for routine low-grade fevers. Thumbs up or thumbs down? I think this is a very, very reasonable statement. I think from my perspective, and we've already kind of you guys have shown your perspective on this. My thinking on the use of acetaminophen in pregnancy has changed after this conversation because it was a risk I was not aware of. Now, is it strong? Is it a strong association? Is it a robust, high level association? I think we've all agreed that it's not there. But I do think I've moved away from my initial stance, which could be where I was different from everyone else, where I thought it's completely safe in pregnancy and there's no risk. And I've
Mm.
moved a little bit away from that into recognizing that there could be a risk, which will change the way I'm thinking about how I would talk about this association otherwise. What do you guys think?
well, I have I have even more thoughts about that. Which okay, that and to be fair, I totally respect that position, and you maybe moved a little bit more, not quite to this side, but a little bit more judicious, possibly. Um, I think my issue is that, we know again that everything we do comes with risks, right? When we eat the ultra processed foods, there may be a
Mm.
risk. Nothing's been proven yet. Microplastics, maybe we don't know, right? There's all the and people are well within their rights to, like, just in case, right? Move towards switching their plastics out in their house, or right, even though we don't have like concrete, strong evidence one way or the other. And that is, people are well within their rights. I think my issue with this statement comes is actually that it's focusing so much on maternal responsibility and maternal discomfort and maternal responsibility for autism, when there's actually data that also suggests that the older the dad, the older the sperm, even though they get recreated all the
Right.
time, the older the dad, the higher the risk of someone having autism. But we don't have a letter like that about that. And so I just, you know, in general, yes, is it a bad thing to say minimize pharmaceuticals, like minimize drugs? I don't think that's a horrible thing to say, but I think when in light of, when you're not looking at it as a silo and you're realizing there's like the social media kind of push, there's the, headline push, and then something like this comes out. I think what it conveys to people, even though it's not technically written, is Tylenol causes autism, even though that is not what they're saying in this, and I recognize that. And so I feel like if we really want people to be risk averse, then we should be talking about all the things that increase or possibly potentially might increase the risk of autism. And I don't think we're doing that. And so again, I think we put the burden on women. Women, it's okay if you suffer, but we're not going to say anything about the fact that, like, if you're a lot older and you have a child, which again, I'm not trying to restrict that. I'm just saying that there is data there too, and good data there. And so, anyways, that's my spiel.
The scientist in me is looking at this like, having written many grants and scientific manuscripts. I'm like, where are the citations? I'm looking for the superscript that will lead me to the citations, because in that sentence, in that paragraph above the one you have highlighted, Shalon, to be clear, while an association between acetaminophen and autism has been described in many studies. So the Swedish study that we just discussed I almost wish the citation were there so I can go fish through the citations. And then acknowledgement in the latter half of that sentence. And there are contrary studies in the scientific literature. It's almost like putting that phrase aside, despite contrary studies, meaning it's really unclear. The only acknowledgement is that a causal relationship has not been established, but all the rest of the letter is that nonetheless, despite what we just said, really minimize use of acetaminophen. And I just kind of wonder, for any fetal medicine specialist, any OBGYN with a patient before him or her, and saying, well, for decades we have known about the perils. Maternal fetal medicine specialists have advised against alcohol intake and tobacco use, right, and drug use during pregnancy. So now you add acetaminophen. Now this letter makes me think, well, what's next? Without strong basis and acknowledging a very uneven platform of scientific data or lack thereof, it's like really now we're picking on acetaminophen. Well, what else is there left? And so is this the beginning, coming in with preconceived notions of what there would be? And again, I just come back to what I said earlier in the conversation, that seems like there's this artificial deadline that by fall 2025, there had to be a solution that scientists have been endeavoring for decades to come up with. But within the calendar year 2025, there had to be a solution. And I'm just worried on another level of concern that this is just it. And this FDA letter just put a capstone on it saying problem solved, it's acetaminophen, and now the most nebulous sentence ever, clinicians should consider minimizing the use of this acetaminophen. A lot of conditions in there for routine low-grade fevers. So it's just, I don't know. I feel like there's a lot of evidence-based approach lacking here. And acetaminophen is just the latest thing. What's next? Well, next week there will be something else.
Well, we're not here to talk about what may be coming next, and we're not talking about the political desire to maybe come up with a solution. We're really trying to give our listeners and our viewers our varying perspectives on this issue, to highlight that it's a discussion and there's really no clear answer, which I think the three of us completely agree with as well.
Absolutely.
And the last part of the sentence is really that this consideration should be balanced with the fact that acetaminophen is the safest over-the-counter alternative in pregnancy amongst all analgesics and all antipyretics, and aspirin and ibuprofen have well-documented adverse effects on the fetus. Do we agree with that statement?
I think on that statement, like, good job, Martin. Like, I'm glad that is the last sentence on there, because I think that's a really important kind of consideration, and I'm glad that he had put that there, because I think that is, again, I will say this practically every episode, life is full of risks and benefits, and we have to navigate all of those, and that sentence is critically important.
This has been an absolutely fantastic discussion. I really appreciate that I was able to sit and dissect the data and these statements with you in a safe environment and come up with different opinions while looking at the same burden of evidence. I think this is lacking, and this is a space that we're looking to help fill for our listeners. On the topic of Tylenol use, prenatal Tylenol use in pregnancy, Emil, do you have any closing statements?
I just think just worried about jumping to conclusions and what people might extrapolate from this. But right at this time, based on the studies that we discussed throughout this episode, no clear association. In fact, far from it. Definitely more to come, and certainly I always kind of come back to what's going on in a preclinical setting, and understanding if there is some association, and pulling that thread if the data have signal there. But so far, I don't think that would change my thinking on acetaminophen and internal use.
Shruti?
My closing statement is similar to Emil's, but also a little bit different, where science is never in static, right? So what we know today was not what we knew 20 years ago, and it's not what we're going to know in 20 years. And so I think that the world that we live in right now wants answers, and they want answers now. And I get it. I would love answers as well. That would be the ideal situation. But I think a lot of the misinformation and mistrust in scientists is in part because we don't know everything. And we who have been scientists for a long time are actually very comfortable in sitting in that and recognizing that we have to navigate whatever data we do have. Even if it's not a United States study, we have to kind of pull from other, we have to sit in that discomfort. And it's not a fun place to sit, and it takes time to learn how to sit in that. And so I think my closing remark is really just that I think, based on the data that we have right now, I think it is safe to use Tylenol in pregnancy, but I actually would continue to encourage anyone who is doing this work, and researchers who have been studying autism for like decades and decades and decades, to continue to do this work, because it's so important for us to actually be investigating this further, to your point about how many people are diagnosed with that every year. And so It's not that we don't want to find out what is actually causing it. We just don't want to jump to conclusions. Um, and sometimes the answer is we don't know.
I completely agree that we don't know, and I completely agree that the data that we have is making it very hard for us to have a very certain affiliation with either one of those solutions. What makes it different for me for Tylenol and prenatal use of Tylenol versus some of the other examples that we've talked about is that culturally this is a medication which we use for many, many reasons. We may use it for joint pains, we may use it for fever, we may use it because we're feeling a little stuffy. And the threshold in our use outside of pregnancy is very, very low. So from that perspective, this entire conversation, which was brought to light, cart before the horse, Emil, exactly how you said it in terms of the headlines that were interpreted and stuff, it did bring pause to me when I think about the use of Tylenol in someone who is pregnant versus not pregnant. But I completely agree with your takes that there is no association and there's no causal relationship. And Shruti, you are shaking your head, so you disagree.
No, I just think that like it's good to have pause, right? It's good to say there's this new thing and it's good to have pause and then look into it. But I feel like to change practice based on data that is incomplete, right? To the point of like science is a journey and we just haven't gotten fully to the answer yet. And based on the answers we have so far, it doesn't seem to have an association. But I think the pause has to come with like, okay, let's look at the data and then based on that data, make an assessment today because we don't have the 20-year plus future data. So again, I'm not changing my personal use of Tylenol even after looking at all the data, even though I recognize that yeah, we pop Tylenol for everything. In regular life. I don't know. That's my little take at the end.
And that is all the time we have for today, because I'm sure we could keep going on and do multiple episodes on this topic. But I hope that our listeners are able to appreciate that there's a lot of nuance. There's people can have different opinions by reviewing exactly the same data and can have different impacts there as well. Thank you very much for your time, and we'll call it a wrap.